before, can everyone see this presentation?
Yes.
And I am changing the slides. Are you able to see the slides changing?
Yes.
Yeah.
Okay, perfect. So over to you, Hala.
All right. Hello, everyone. So today I'll be talking about the tracheostomy procedure and the physiological changes that occur following this procedure, and also in addition to tracheostomy care, and what or how to handle patients with tracheostomy in emergency situations, basically, and focusing on the differences when you handle a patient with just a tracheostomy only, and patients with laryngectomy. So just a simple definition of tracheostomy, which is a procedure that is basically making an opening in these trachea at the level of the cervical trachea, which results in having a new airway that is connected to a opening on the skin that's called the stoma, which the tracheostomy tube is placed on. And this is usually, as I said, is done at the level of the cervical trachea, which is exactly the landmark would be between the second and third tracheal rings, as shown in this picture. So when is the tracheostomy done? So one of the most common indications for tracheostomy is airway obstruction, which is commonly due to, for example, laryngeal cancer. As you can see, most patients with laryngeal cancer end up having a laryngectomy, but usually the tracheostomy procedure would be done before the surgery, just to basically ensure that there is a protected airway before going into this major operation. Other indications, it could be obstruction secondary to swelling due to infection, or trauma like head and neck trauma or facial fractures as well, which in this case would be an emergency tracheostomy. Depends, of course. Sometimes they would have to do a cricothyroidotomy, so it depends on the urgency of the matter. Other injuries, it could be due to chemical or inhalational injuries as well, that would have a risk of having airway edema, and also, again, it will cause airway obstruction, and that's when the tracheostomy is indicated. So in some cases where patients are unable to protect their own airway, secondary to conditions such as neuromuscular disorder, or following head injuries or strokes, sometimes it could be also due to prolonged intubation as well, where there is the larynx have not been used for such a long time, and there will be weakness of the laryngeal wall. In some cases where there is major head and neck procedures, like, for example, oropharyngeal cancers. So before going into these operations, given that there is a prediction of having an airway edema after these operations, they would do a tracheostomy before, and this usually is a temporary and until the swelling is gone, and then there will be no longer the need for the stoma. Sometimes as well, tracheostomy could be used for what they call bronchial toileting, which is basically in patients that have poor cough effort and they would have sputum retention. So tracheostomy is done with, of course, using mechanisms to assist the patient to get rid of this retained secretions, like using cough machines with also direct suctioning. And of course, the most common tracheostomy indication we see in ICU is due to prolonged intubation, where patients need to be dependent on ventilation for long periods, like some are for weeks and some are for months. And in that case, just to wean off sedation and continue ventilating, they would have the tracheostomy procedure, and that would help also weaning off the ventilator as we go. So types of tracheostomy, the most common ones are percutaneous and surgical. we can also talk about types in case if we can categorize them. As we said earlier, some of them are temporary, some of them are emergency, and some are permanent, like post-laryngectomy. So I included in the types is the percutaneous, which is the most common one in ICU, and the surgical tracheostomy, which is usually done by surgeons, which is a surgical opening, usually done in the operation theatre. While the percutaneous one involves it's a non-open procedure. It's basically inserting a needle through inserting the needle through the neck and then putting a guide wire over this needle, and then using progressively larger dilators just to get the right size of the tracheal stoma, and so to be able to place the tracheostomy tube. So in ICU, this is the most common type, whereas sometimes they would do a surgical one in ICU. Depends on the personnel that is involved. I mean, that is available in the wards. In some cases, also when there is difficult and neck anatomy, surgical tracheostomy would be better as well. Also, in other points to highlight and the differences, for example, the stoma in percutaneous, which the stoma in the tract takes longer to be established. It will take up to 10 days in the percutaneous, whereas in the surgical tracheostomy will just take up to 3 days. So as every procedure, there are complications. So depends on the timing of the complications. So we can get complications within 24 hours after tracheostomy. It could be due to hemorrhage. It depends. It could be minor or severe. Depends on the involved injured blood vessel. Missed displacement of the tube early on within 24 hours. And sometimes this displacement of the tube and actually using that tube could cause results in subcutaneous emphysema, where there is insertion of the tip of the tube into the pretracheal tissue, and that will cause subcutaneous emphysema that could also progress into pneumothorax or pneumomediastinum as well. Sometimes also you could lose the upper airway early on after the tracheostomy. So other complications which may happen in less than 7 days, it includes as well tube displacement. It could also tube blockage can also happen as well. Infection of the stoma or introducing infection to lungs. Also, when the tube is misdisplaced, it could also cause compression on the tracheal mucosa, and that will disrupt the blood supply, leading to things such as ulceration, necrosis, and that would also lead to stenosis on the long run as well. Other things like fistulation, like tracheoesophageal fistula, can happen as well. Later complications which happens in the period after 7 days, like granuloma formation, which is usually due to the stasis of secretions and chronic infection, that could cause granulation tissue, and that could also lead to stenosis. And sometimes these granuloma can also bleed as well, leading to hemorrhage. And of course, if the patient is not being handled very well in ICU, getting the right care, which includes humidification and also continuous suctioning, that could lead to secretions becoming more thick, and they could block the tubes. So as we can see here, these are the types of tracheostomy tubes. We have mini trache, which is around 4 millimeter in diameter. This is a small type of tracheostomy tube. It's not used for ventilation purposes. It's just only used, for example, when we're preparing the patient for decannulation, we're in emergency situations where we need to secure the patient's airway, and also for things like bronchial toileting, as we explained previously. This one is the fenestrated tracheostomy tube, which has opening, and that would allow air to pass through into the upper airway to the nose and mouth, and will help the patient to speak. So it depends on the inner cannula that we use with this fenestrated tube. So if you want to keep using or maintaining the fenestration, we could have an open inner cannula, but in case we want to close it, we can use a blocked inner cannula, and that would be considered when handling patients who have high risk of aspiration, where we don't want any secretions passing from the upper airway into the trachea and the lungs. This is a uncuffed tracheal tube, tracheostomy tube, which doesn't have a cuff. Basically, it's used when we're preparing patients to wean off tracheostomy. And this is the cuffed one, which basically it has two purposes. So one, it will prevent any risk of aspiration. And second of all, also when we want to use positive air pressure when we're supporting a ventilated patient, it will become in handy. Whereas when we have an uncuffed tube, we can't apply any pressure supports. So just giving a simple definition of laryngectomy, which is a surgical removal of the larynx. Usually it's a total removal of the larynx. So it's usually used in advanced stage of laryngeal cancer. And of course, when this happens, it will disconnect the upper airway, which is nose and mouth, from the esophagus, from the trachea, basically, and will just maintain the connection to the pharynx and down to the esophagus. So the patient will be a neck-only breather, where they only rely on breathing through the laryngectomy stoma. This is just to show pre and post laryngectomy, where there's a larynx, and then when the post laryngectomy, when there is no connection between trachea and nose and mouth, and the patient is just basically a neck only breather. So we're just going to go through the physiological changes that occur following tracheostomy. Well, and most patients with laryngectomy would be affected to a higher degree with the changes that they go through after this procedure. So coughing is a reflex that is highly affected in tracheostomy, but it will be more affected when post laryngectomy, as the larynx will be completely removed. As we can see, the normal cough physiology is highly dependent on laryngeal muscles. So going through the physiology, it will include first inspiratory phase, which is basically air going into the lungs, and then creating an intrathoracic pressure, which builds up against a closed glottis, that's the compressive phase, and then followed by sudden release of this air. So once we lose the larynx, then cough will be affected. And that, of course, will increase the likability of having chest infections due to loss of cough reflex. And again, as I said, when a post-laryngectomy, there is no connection between the upper airway and the trachea, there will be reduced nasal function, where the patient cannot rely on the nose to protect the airway by humidifying the inspired air and filtering and moistening the air. Swallowing as well is one of the functions that are highly dependent on laryngeal muscles. So patients going through laryngectomy would have to be assessed by SALT and rehabilitated after surgery to be able to regain swallowing without depending on the laryngeal muscles. Valsalva maneuver is one of the also functions of the laryngeal muscles, which is basically dependent on holding the inspired air against a closed glottis, and that would be that would help to generate increased intrathoracic pressure to help the patient to stabilize their abdomen and trunk and be able to do things like lifting heavy objects and opening bowels. And one of the things that we have to be aware of and actively avoid is constipation after laryngectomy procedure. Speech, which is one of the distressing consequences of laryngectomy, where the patient can not be able to communicate. So yes, that is also needs to be looked after, and also going through rehabilitation. And so moving to routine care of tracheostomy stoma. So as we previously explained, patients would need help with humidifying the air. So humidification it comes in two ways: active humidification and passive humidification. So this is basically a machine that will bubble the air, or sometimes when we use oxygen, and with also using heat to increase the heat and water content in the inspired air. But these are simple measures to help patient passively. So this is a Buchanan PIV, which is a neck-worn apron that covers the laryngectomy stoma, and basically it will help filtering and humidifying air. This is a Swedish nose, which can be fit on the stoma or also connected to the tracheostomy tube, that also helps to maintain moisture. And this is the humidifier and moisture exchanger, which contains a foam inside. So how this functions is basically when the patient expires air, it will reserve the heat and moisture that's coming from the patient's own air, and then it will be used once the patient takes a breath during inspiration. This is the same method. It contains a foam inside. It's like a button, and the patient could be able to put it on the laryngectomy stoma, and it will function as a filter and also a humidifier of the air. Other measures to help patients with humidification is using things like nebulized saline or mucolytics, either nebulized or systemic, like carbocysteine, which we commonly use in ICU. So when cleaning the stoma in laryngectomy patients, we advise them to clean at least 3 times a day. We advise them to stand in front of the mirror to get a better view of the stoma. Clean it basically with sterile water when it's in the period of healing, but once it's healed, they could use tap water and tissues. Tilly forceps also can be used to remove any dried mucus around the stoma, as well as some barrier creams like Vaseline to help manage irritation around the stoma, and that will avoid granulation tissue formation as well. So the stoma care in trachea patients, basically when they're still in ICU, of course, the aim is to keep it as clean and dry. So we advise to change the dressing at least 24 hours, every 24 hours, but it depends according to the amount of secretion the patient produces. Sometimes it would need more than that. We usually use a pre-cut dressing by the manufacturers just to avoid any loose fibers going into the stoma down to the airway and causing infections, and as well just using barrier creams and just to avoid irritation or excoriation around the stoma, and again to avoid things like granulation tissue. So when we fixate the tracheostomy tube, we use things like neckties and sutures. So once the patient has the tracheostomy tube, the sutures have to be removed 7 days after the procedure, unless there is an emergency where you have to have a suture scissor available, and that would be an emergency situation where you need to remove the tracheostomy tube on in the event. So these are the ties that they use to stabilize the tracheostomy tube. This is a cotton and Velcro tracheostomy tube holder. So always in ICU patients, we have to make sure that the ties are not too tight around the neck. We have to make sure that it's at least one finger. There's at least one finger between the tie and the neck skin. Especially when patients are sedated, they're not able to reposition themselves. This is a wound that can occur due to the tracheostomy ties. And of course, changing these ties require two pair of hands, which are two people, one that will hold the tracheostomy tube and the other would change the dressing and the ties. When cleaning tracheostomy tubes, we have what we call here the inner cannula, which makes it easy to do without removing the whole tube. The minimum to clean and change the tube is at least 8 hourly during a shift, basically to remove any retained secretions or that could block or cause obstruction of the airway. Another thing that we have to also continually provide in ICU is maintaining suctioning, in addition to good humidification and also good hygiene of the tracheostomy stoma. We have to continuously make sure that the stoma is suctioned, and the frequency of suction depends on the amount of the secretions the patient would be producing. This is a closed suction, which usually is attached to the tracheostomy tube, and it will allow us to do suction without removing the ventilator. So all the suction tubes come in numbers, they come in diameter, and the number depends on the diameter of the tracheostomy tube. So there will be like a table that would have the right number of each tracheostomy tube that and the right number that goes with the to have the suitable suctioning tube that goes with it, to avoid inserting the tube further down. That may cause injury and sometimes even vagal episodes when reaching the carina as well. Basically, this is to show how the cuffed tracheostomy tube would provide any aspiration. As you can see here, there is also what we call a subglottic suction port that would avoid any minor secretions that could may slip around the cuff, and that would allow continuous suctioning even with the cuff up. So when having the cuff inflated, we have to make sure that it's in the right pressure. So we usually have to keep it between 10 to 18 millimeter mercury, so they would not disrupt the blood supply to the mucosal lining of the trachea, and that, as we mentioned above, could lead to ulceration, and that would also progress to stenosis and also fistulation as well. So usually the cuff has to be checked at least 8 hourly during a shift. If a cuff requires more than 10 mL of air, or there is frequent reinflation, then that's an indication that the cuff is either damaged or misplaced. So we have to make sure that that doesn't happen. Also, there are complication of the cuff being underinflated is we get air leakage, which will lose the purpose of ventilation. It also permits microaspiration and increases the risk of pneumonia. So this is when we need to change the tracheostomy tube, as some patients would need to adjust the size of the tracheostomy tube according to the size of the stoma, and sometimes in emergency situations as well. So we have to make sure whenever we need to change the tracheostomy tube, we have to have the right personnel and the right equipment immediately available. Patients should be in the right position with extension of the head and having their shoulders supported with pillow. And of course, we have to ensure that the cuff is deflated and suctioned as well. So if this is a first tube change, then it's better to change the tube by using a bougie. So basically you put the bougie in through the used tracheostomy tube and you pass it over the bougie, and then you put the new tracheostomy tube over, just to make sure that you're maintaining a secure airway while you do that. If there is any difficulty in changing a tracheostomy tube, that has to be documented so that the staff would be aware of that. And this is when the tracheostomy passport is useful. This is, again, if changing the tube is complicated, for example, it's a first tube change, or it's in obese patients, or it's an early stage post-percutaneous tracheostomy. As we mentioned before, in percutaneous tracheostomies, the tract usually takes up to 10 days to be established. So we have to make sure that we, again, have the right staff, and also make sure that we go through the right steps that we mentioned just now. In case the patient is on ventilation, then we have to pre-oxygenate the patient before changing the tube. And of course, if reinsertion proves difficult, then we would need to sometimes do redilatation of the stoma and the tract. One of the things that the patients after tracheostomy need are physiotherapy, chest physiotherapy, given that there is high risk, high possibility of bronchial secretions being retained in lower airway. So there are many techniques. So I'm going to go through 4 of them just now. So one of them is active. This is like a breathing technique that a spontaneously breathing patient is able to follow. It's called active cycle of breathing techniques. Basically, we tell the patient to take a cycle of relaxed breaths, and then they hold the breath and they do forced expiration after that. Manual hyperinflation is done on intubated and ventilated patients, where we administer passive positive pressure to inflate the lungs, and then we would let the air release on its own without applying any pressure. And this will help to clear the sputum and also recruit any areas of collapsed lungs as well, and improve lung compliance. Cough assist is basically the same as manual hyperinflation, but it's sort of an extension to it, because we do positive pressure in the beginning, but then at the level of expiration, we do negative pressure. So that will replicate the cough mechanism. It's usually done by connecting the tube to a machine called insufflation exhalation device, which is a cough machine. In case where the patient is a tracheostomy patient, you can attach the tracheostomy tube to the machine via an adapter. And of course, using pharmacological therapies like saline nubs or mucolytics also could help patients with clearing their chest. Other things that patient need, trachea and laryngectomy patient need, is nutrition, given that some of them are already malnourished in cases of patient with laryngeal cancer or patient post-tracheostomy where their swallow is affected. So it depends on what stage the patients are. So some of them could be orally fed, but some would need, especially in the beginning, NG fed or nasojejunal tube. Sometimes we need also PEG. And sometimes, of course, we do use TPN. So now we're going to talk about how to manage patients, deteriorated patients with tracheostomy. And we also want to focus on the differences when we're handling a laryngectomy patient rather than a tracheostomy. So how to recognize red signs or red flags. So starting with airway. So when a patient is having a cuffed tracheostomy tube placed, and he's able to talk, or you hear audible air leaks or bubbles in his mouth, then that means that the cuff is either damaged or not inflated. When patients have noisy breathing, they become stridorous, or they would start snoring when basically they don't, at their baseline, they don't snore, or they start having grunting. Another cue we can also pay attention to when the patient is connected to a capnography when we see a flat waveform or a change in the waveform in a ventilated patient, then that is indication of a problem with the airway. Other things that we can also pay attention to when we need to recognize that this is a laryngectomy patient and he just only has one airway, which is the stoma. You can see things like medic alert bracelets. You can also see a bedhead sign that says that this is a patient with this is a laryngectomy patient who only have one airway. You can also pay attention to things like when a patient has a button that's placed on his tracheostomy that could tell us that he's a laryngectomy patient, or when the neck is not covered and there is a sunken neck, which leads us to thinking that the larynx is missing, or maybe seeing surgical scars as well could be a hint. There's also another sign for tracheostomy patients, which also is on the bedhead, and it has to be visible. Also, you can notice that patients getting anxious, hypoxic, and using accessory muscles with increased respiratory rate. In case of if they're ventilated, then you can notice lower tidal volumes or higher airway pressure. They start to become tachycardic and hypertensive in the beginning, but if they continue to deteriorate, that could change to becoming bradycardic and hypertensive and may go into arrest. Specific tracheostomy flags, again, seeing a visibly displaced tracheostomy tube or blood around the stoma. When patient report increased discomfort around the stoma as well, or things like air leak, which indicates that there's a problem with the cuff. So this is a trachea case that has to have all the essential equipment like oxygen mask, laryngeal mask, airway, pediatric face masks that we use over the stoma. These are oral and nasal adjuncts as well. So usually in this case, we have to have spare tracheostomy tube. A minimum should be one spare tube of the same size and another one size below of the size of the patient that's using in that case, and also spare inner cannula as well. Tracheal dilators, things like suction machine, endoscope, PPE, and scissor and stitch. So again, the most important steps to manage a deteriorating tracheostomy patient is, first of all, you have to recognize, is this a laryngectomy patient? Is he a neck-only breather? Is he known to have a difficult airway? So first thing, you have to call for help. You oxygenate the patient. So if there is confusion whether this patient is a neck-only breather or not, and you're not sure, you can always apply oxygen to both face and tracheostomy, basically the stoma and the face, as this is not going to harm the patient, but just to make sure that we're not missing anything. And then you would start, of course, assessing the patient, assessing the patency. We will go through this in the algorithm in the next slides. So in emergency situations will be primary responders, which include nursing staff, junior medical staff, sometimes ambulance crews, physiotherapists as well, and trained carers. And the secondary responders, which are they're more trained and have advanced airway and tracheostomy management skills that include anesthetics, critical care doctors, advanced practitioners or specialist nurses as well, or ENT maxillofacial staff, either medical or nursing. So this is the algorithm. So we're going to start with tracheostomy management patients. So in the beginning, of course, you would have to call for help. And then you would start with the approach of look, listen, and feel by doing the maneuvers that we're used to, which is head tilt and chin lift, and to look, listen, and feel. If he's known a tracheostomy, then we would have to apply this on the mouth and stoma. And at this stage, you can also connect to a waveform capnography as well. So if the patient is not breathing, you would have to start CPR. If there is signs of breathing, then you'd start assessing tracheostomy patency. At this point, you would remove any cap, any speaking valve, the inner cannula as well. And then you would start to put the suction tube and see whether you'd be able to suction and pass it through. So if not, then in that case, you deflate the cuff, and again, you assess by look, listen, and feel approach, and you looking to the waveform capnography. In case that, again, after deflating the cuff and there is no signs, then you would proceed with removing the tracheostomy tube and assessing again. If the patient is not improving or is not breathing, then you would have to do so it's divided into primary emergency oxygenation or secondary emergency oxygenation. So in primary emergency oxygenation, you would approach with either the mouth or the stoma itself. So basically, when we do oral airway maneuvers, we cover the stoma with hand or swab, and then we can use things like a bag valve mask, oral nasal adjuncts, or LMA. If we want to approach the stoma, we can use the pediatric face mask or the laryngeal mask airway. Of course, if this doesn't work, then we would go to secondary emergency oxygenation, and this includes an oral intubation. You can also attempt intubation through the stoma, and in this case, we would use a small tracheostomy or a size 6 endotracheal tube that is commonly used through the tracheostomy stoma. Another thing that we can do, which is safe as well when approaching a stoma, and we also want to make sure that we're going into the right tract, is using what we call an tray catheter, which is basically passing an endoscope through either a laryngeal mask or through the bougie catheter here, through the bougie here. So this is to give us a good visualization of where the tip of the bougie or the laryngeal mask is going, and ensure that we're putting it in the right place. So also sometimes when approaching stoma and not being able to go through the stoma by intubation, we would resort to surgical approach, either doing an emergency cricothyroidotomy or redoing the tracheostomy itself. And now we would go through the laryngectomy management algorithm. So again, calling for help is the first thing, and then assessing the patient by look, listen, and feel. So if the patient is breathing, then you would apply oxygen. And again, just to avoid confusion, you can put it on, when you're not sure if this is a laryngectomy patient, it's okay to put a face mask and a mask over the laryngectomy stoma. And then you would start assessing the stoma patency. So at first you would remove things like inner cannula. If there's a tracheostomy, so not all laryngectomy patients have a tube, but in case there's a tube, you would remove the inner cannula, remove any covers like the humidification button, and then reassess. So you put the suction tube and see whether you'd be able to pass it through. If not able, then you'd have, if there's a tube, you deflate if the tube is in and it's a cuff tube, you can deflate the tube. If the patient is improving, then you would continue with ABCD approach. If not, then you remove the tube and again reassess. If not improving, then you would go through emergency oxygenation. And in this case, since it's a neck only breather, then you just only approach the stoma, either using a pediatric face mask at the beginning or using the LMA. And then again, if this doesn't work, then you would approach intubation by using a small tracheostomy tube or a size 6 endotracheal tube, which is the same as in the previous algorithm. You can use an entree catheter, which is a scope passed through a bougie or an LMA. And this is the end of the presentation. Thank you all for listening.
Thank you very much, Hala. Does anyone have any questions? I cannot hear you. Somebody, if anyone has a question, can you please raise your hand? So, very good presentation, Hala. One thing I would always stress upon is that we would like all of you to go through the Research Council UK's algorithm about obstructed or displaced tracheostomy and laryngectomy tube. One of the managements that you should remember in mind, which you rightly pointed out, that in case of laryngectomy, there is no air to escape on the top. So as a result of which, if there is any kind of obstruction, this patient needs an emergency, and whatever the airway management you're going to do is from the neck and not from the mouth. Otherwise, in case of obstructed tracheostomy tube, the moment you remove the tube, it's better to cover the neck and start ventilating from the top, which you cannot do it in laryngectomy. Okay. After, I think the next presentation is now by Kalaimathy. So, are you ready with your presentation? Kalaimathy, are you there? We cannot hear you. You are mute if I'm not mistaken.
Yes, I have unmuted.
Okay.
Can you see my presentation, not there?
No, now we cannot see it.
Can you see it now, Amaya?
Yeah, we can see it now.
1 second, I will move it.
Your slides are not scrolling if you are trying to scroll them.
Is it visible now?
I can see only one slide, but I don't know whether you're changing the slides or no.
I'm changing. I'm changing. Hello?
No, we cannot see the slides change.
Okay, let me try again.
Yeah, can you stop sharing and retry sharing one more time?
Sure. Can you see it now?
Yeah, we can see your slide.
Okay, is it rolling?
Yeah, now we can see it's
okay.
getting
And I made it to the NTS full screen. I'm
Yeah,
trying.
you can make it full screen.
Is it rolling now?
Yeah, yeah.
Okay. So can I start, Amaya?
Yeah, you can. Yeah,
Okay.
over to you.
Good evening, everybody. My name is Kalaimathy. I'm one of the IT registrar. So today I'm going to discuss regarding the critical care management of bronchial asthma and COPD. So I'm mainly concerned about the ventilatory management, but initial management also I'm just touching on few words. So why we need to talk about this? Because the bronchial asthma affects nearly 300 million people worldwide, and in Europe, 30 million of people are affected with bronchial asthma. According to the WHO data, in UK, asthma-related deaths per 100,000 population is only 1.06, so it's not a great amount. And the most of the asthma exacerbations are respond to the initial treatment, and it can resolve in several hours. But only problem is like if certain amount of patients can get admission to the intensive care unit. Among them, 1/3 of the patients need mechanical ventilation, and in those group of patients, the mortality rate will go up to 8%.
Sorry, Kalaimathy, your slide hasn't changed.
It's not changing.
Yeah, it's still on the opening slide.
Oh, is it changing now?
Yeah, now it's changing.
Okay. So I think I can move. Do you want to repeat it? Hello?
No, that's fine. No, that's fine.
Okay. So if we are considering the pathophysiology of asthma, in asthma patients, the airways are characterized by airway smooth muscle hyperresponsiveness, and there is a bronchial muscle constriction and the thickening of the airway wall, and excess production of the mucus and decreased clearance, so it will causes mucus plug. And so both airway narrowing and the mucus plug can cause airway obstruction. So especially expiratory airflow is getting obstructed, so the patient is unable to exhale fully. So there it will causes air trapping in the lungs. So if it is occurring progressively, then it will causes increased expiratory lung volume and dynamic hyperinflation of the chest. So if extreme hyperinflation continues, then it will causes increase in the intrathoracic pressure and leads to development of intrinsic pain, which normally measured at the end of the expiration. So both hyperinflation of the chest and the increased airway resistance can compromise the diaphragmatic movement. So at this stage, the patient normally compensated by using the accessory muscles of inspiration and expiration to maintain the minute ventilation. So it will, with time, it will lead to increased work of breathing and the fatigueness of the respiratory muscles. So if it is not reversed at this stage, then the patient may not able to maintain the alveolar ventilation for a long time. So it will end up in hypercapnia and dangerous hypoxia. So finally, in acute respiratory failure. Depending on the severity, the asthma can be divided. Acute asthma can be divided into acute severe asthma, life-threatening asthma, and the near fatal asthma. So normally the acute severe asthma can be managed in the emergency department. So as from the ITU point of view, sometimes we may encounter the patients with life-threatening asthma or near fatal asthma. So in life-threatening asthma, the peak expiratory flow rate is less than 33% of the predicted value, and the patient couldn't maintain the saturation more than 92%, and the PO2 value is less than 8 kilopascal, and they may show the signs of poor respiratory effort, silent chest, and features of hypoxia such as cyanosis, arrhythmia, and hemodynamic instability, and altered level of consciousness. But the arterial carbon dioxide level remains normal in life-threatening asthma. But in near fatal asthma, their carbon dioxide also rise and it start to accumulate. And these patients definitely need mechanical ventilation with the raised inflation pressures. So in initial management, I'm briefly discussing about that. So we should start with supplemental oxygen in all patients who are hypoxic in and acutely severe asthma. So they should maintain this target SpO2 of 94 to 98%. And the salbutamol, the short-acting beta-2 agonist, should be started by the nebulization. That is the first line management. But if it is not responding, sometimes we may need to go for a continuous or back-to-back nebulization. If this patient is not suitable for the inhalation technique, or if it is not responded to that, we may try intravenous beta-2 agonist. And all patients should receive a corticosteroids, normally orally, but if they couldn't tolerate oral, then we can consider IV ketocortisone or IM methylprednisolone. And additional bronchodilator therapy should be with the nebulized ipratropium, especially with life-threatening or severe acute severe asthma. If those standard treatments are not responsive, then we can consider the magnesium sulfate and aminophylline. So it should be tried as a single IV dose. And aminophylline also can be used, but these two therapy need a specialist opinion. So even after this initial management, if the patient is not responding to the treatment, then we should consider moving this patient to a HDU or the ITU setting, and should consider the assisted ventilation in the form of non-invasive or the invasive ventilation. So these are the indications for transferring the patient to a specialized unit, maybe an HDU or the intensive care unit. So the first one is the lack of response to the initial aggressive management. Another one is the presence of risk factors for the potentially fatal asthma, such as poor compliance with the treatment and increasing use of oral corticosteroids and reduction of the use of inhaled corticosteroids, and patients who had a previous history of mechanical ventilation and recent or frequent hospital admissions with acute severe asthma. And if the patient unable to do the peak expiratory flow or test or the spirometry, or there is a deterioration in their performance, and inability to maintain the oxygen saturation more than 92%, and persistent respiratory distress with hypercarbia and development of respiratory muscle fatigue. These patients should be moved to the intensive care unit, and they can receive an assisted ventilation either in the non-invasive or the invasive method. So if we are considering the non-invasive ventilation, it is not currently recommended routinely for the asthma patients, but it can be used in a selected cases. I will show the patient groups who are getting benefit with the NIV on my next slide. And if we are starting the NIV, that should be under close monitoring in intensive care unit or high specialized unit with the experienced clinicians. And it should be best delivered with the tight fitting full face mask interface. And compared to the invasive ventilation, it have several advantages, like it needs less sedation and the patient can free to talk, and the ventilatory support can be temporarily disconnected to allow the patient to take oral intakes or can cough and expectorate. And there is also a reduced risk of ventilator associated pneumonia. So these are the patient groups, they are getting benefit or they are more suitable for the non-invasive ventilation. So if the patient is remaining relatively stable and expected to respond for the aggressive treatment in next few hours, that is one indication for non-invasive ventilation. And in patients who are becoming fatigued due to the high work of breathing, we should consider non-invasive ventilation. And if the patient remaining alert and cooperative and able to perform the spirometry and the peak expiratory flow rate, then we can consider in those patients. And if they can able to maintain the saturation of more than 90% and the PCO2 is less than 45, so not severely hypercarbic, and there is no excessive coughing, vomiting, and the patient is hemodynamically stable, then we can consider starting non-invasive ventilation in these patients. But if they are not following under these categories, then we should think about intubating the patient and starting mechanical ventilation. So the main goal of non-invasive ventilation is to allow the patient rest, especially the respiratory muscles to be rest, and we can buy the time for the other therapies to work. So, and we can avoid the intubation and the invasive ventilation by reducing the respiratory workload. But even during the NIV, we should continue the bronchodilators. So that can be given when there is an NIV rest. That means when the mask is disconnected from the patient face, or even if we couldn't do that, that means if the patient is still depend on the NIV, then we can connect the nebulizer or the metered dose inhaler through the ventilator circuit with the NIV. So the bronchodilator therapy, to titrate the dose, we can't really rely on the presence or absence of the wheezing, because the presence or absence of wheeze is poorly correlated with the airflow obstruction. Even if the patient is not responding to the next 30-minute time, we should reassess the NIV setup, whether we can optimize the support we are providing with the NIV, and we can change the different mask and the interface, and we can consider using a judicious sedations without affecting the patient airway maintenance. And if everything failed, then we should think for intubation and mechanical ventilation. So this chart showing the indications or indications for mechanical ventilation in acute severe asthma. So while the patient is in NIV, if the patient is exposed, patient become exhausted, or if the level of consciousness coming down, and if there is a signs of respiratory muscle fatigueness and increased work of breathing, and if the patient developed hypercapnia or refractory acidemia, and even with the NIV, patient couldn't maintain the oxygenation and become cyanosis or hemodynamically unstable, then this patient should go for intubation and mechanical ventilation. Even though we are considering intubation and mechanical ventilation, it is not ideal for every patient with potentially fatal asthma, because even this procedure can accompany with serious complications during intubation or mechanical ventilation. So unnecessary intubations should be avoided. So if we decide to intubate, that decision should be made after aggressive treatment with anti-inflammatory drugs and the bronchodilators, and the decision should be clinical rather than going with the specific numbers or the values related to the ABG. And ideally, it should be done electively before the patients collapse with the respiratory failure. Intubation also associated with hypotension and increased risk of gastric aspiration. So if we plan to do the intubation, that should be done with the modified rapid sequence induction. So we can use ketamine because it's have a bronchodilatory effect, or even we can use the propofol with the muscle relaxer. So after the intubation, we should decide about the mechanical ventilation. So the acute asthma patients who already intubated and on mechanical ventilation, we can divide them in two groups depending on their ventilatory behavior. So one group is like patient is exhausted, but still they are having preserved lung function moderately. So in these patients, only they need the rest for a certain time, and for them the ventilation is not much difficult. But on the other hand, the patient is already exhausted and they have extreme degree of airway obstruction and the hyperinflation of the chest. So in these patients, the ventilation will be really difficult, and we need to adapt special ventilatory strategies to prevent the severe dynamic hyperinflation. So these are the initial ventilatory strategies that we need to practice when we are doing a mechanical ventilation. So our aim of oxygenation should be more than 92%. So we can use 100% oxygen initially and then titrate according to the target. And we don't need to rush to control the PCO2 or hypercarbia. We need to titrate the mechanical ventilation to the pH especially. So our target is to keep the pH of more than 7.1. So in these situations, we may need to give a bicarbonate to maintain that. And our other aim is to minimize the hyperdynamic dynamic hyperinflation. So that can be achieved by using a moderate rate of moderate frequency of ventilation with 8 to 12 breaths per minute, and the low to normal tidal volume of 6 to 8 ml per kg. And the inspirated flow rate should be maintained more than 60 liter per minute, and the inspirated time should be minimized and allow more time for the expiration. So then it will allow more expiratory air can be escaped. And the peak inflation pressure should be less than 50 centimeter water, and the plateau pressure should be less than 35 centimeter water. And at the beginning, the PEEP should be started with the low level from 5 centimeter water, and then progressively we can increase gradually only. So if we found that patient is not cooperating with the ventilator, or there is a patient ventilator dysynchrony or agitation, then we can consider using sedation with opioids plus or minus muscle paralysis to overcome that synchrony. So there are potential complications that can occur with the mechanical ventilation. So they can develop immediately after intubation or even later. So such as hypotension, it may be due to the induction drugs which we used for the intubation, or it may be secondary to the hyperinflation of the chest. So, and the auto PEEP, so that will reduce the venous return to the right heart, and the cardiac output will be less. So that can cause of hypotension and hemodynamic instability. And there may be a risk of arrhythmias secondary to the hypoxia, as well as the drugs we are using, especially the beta-2 agonist. And there is a risk of hypoxemia and hypoventilation. If the patient having a pre-existing pneumothorax, that can get worse with the initiation of the positive pressure ventilation. And the patient can be agitated and biting on the tube and having dysynchrony with the ventilator. So in that situation, as already discussed, we can use a sedation with or without paralysis. And there is a chance of worsening of hyperinflation. So that can be reduced by having a high, that can be due to high respiratory rate or high ventilatory tidal volume setting. So we need to maintain a low respiratory rate and low tidal volume to overcome this. So this is the ventilator graph, the flow time graph showing the air trapping and the development of auto-whip. So the lines with the dots shows the normal graph that occur in normal healthy individuals, but the dark line shows the air trapping, so it will not touching the baseline in the graph. So the complications and how we can solve these, I think I have already discussed few things like agitation, already discussed, and patient ventilator dysynchrony. We can disconnect the patient from the ventilator and allow the gas that already trapped in the airway or lungs to be come out, and then we can assist them with the 100% oxygen with self-inflating bag or the Mapleson C circuit. And if the patient develops hypotension, it can be due to several causes. So first thing is due to the hyperinflation and the auto PEEP. So we can disconnect them from the ventilator, and If the patient develops sudden and persistent hypotension, we should think about the possible tension pneumothorax. In that situation, then we need to do an urgent decompression and followed by a chest drain. So if we found it's very difficult to ventilate the patient in that situations, very rarely we can use the Keliox to relax the airway, or sometimes the inhalational or intravenous anesthetic agents, for example, propofol infusion, may be considered to allow for the mechanical ventilation. If we consider the weaning, most patients with asthma will improve quickly after certain period, maybe 1 or 2 days of time, and they can be extubated straightforward. But especially they can be easily extubated if their problem is especially due to the fatigue and their lung mechanics are not badly affected. But if the patient's lung mechanics already badly affected and they affected, and these patients will improve very slowly and the weaning will be difficult in these patients. So we should do more gradual weaning process with the specialist advice. So all the patients who had assisted ventilation should be seen by an asthma specialist before the discharge, because these patients are more prone to develop near fatal asthma in the future. So that's about asthma. I can move to the COPD. The COPD is a progressive inflammatory disease of the lung. It is characterized by airflow limitation, but here the airflow obstruction is not fully reversible. And also it can be associated with significant systemic manifestations and other comorbidities. So acute severe asthma, where the worsening of respiratory symptoms of acute severe exacerbation of COPD, where the worsening of respiratory symptoms of COPD occur. So that is characterized by worsening of dyspnea, cough, high volume of sputum production, and the purulent sputum and wheeze. So that can be triggered by respiratory tract infection, pollution, and change in the atmospheric pressure. So the pathophysiology of COPD, here chronic inflammation of the smaller airways and the lung parenchyma occur, secondary to the noxious stimuli, especially the cigarette smoke. So the lung pathology in the COPD is with a combination of small airway disease that is characterized by the obstructive bronchitis and the parenchymal destruction that is characterized by emphysema. So in each individual, these two pathologies will be contributing in a different percentage and the patient will be having a COPD. So increased airway resistance and decreased elastic recoil lead to limited airflow. So that will impair the ability of the airways to remain open at the end of the expiration. So again, as same as asthma, this will lead to air trapping. So that can occur chronically or sometimes in an acute stressful situations, the dynamic air trapping will occur. The dynamic hyperinflation again affects the ventilation perfusion ratio. So the mechanics of the respiratory muscles also affected. So that will cause us marked dyspnea. The loss of parenchyma in emphysema causes decrease in the gas transfer, and pulmonary capillary beds number of capillaries in also less, so it will worsen the VQ mismatch. At the end of the end results, the VQ mismatch decreased gas transfer and alveolar hypoventilation. It will result in hypoxemia and sometimes hypercarbia. So in addition to these respiratory changes, the COPD patients can have secondary copulmonale or skeletal muscle wasting and cachexia. So this is the gold classification of COPD depending on the post-bronchodilator FEV1. So depending on the severity, classified into mild to severe. So in mild disease, the FEV1 is more than 80% of the predicted value, and in moderate it's 50 to 80%, and severe disease 30 to 50%, and very severe disease it's less than 30%. Again, the initial management, it's including the bronchodilators and steroids. But in addition to the asthma, we should give antibiotics in acute exacerbation of COPD patients, especially who are admitted to the ITU. But in non-ITU admitted patients, the choice of antibiotic and the duration in which it should be used, it's not proven. And supplementary oxygen should be given to the patients with COPD who are hypoxemic, but we should have a control oxygen therapy and should have the lower target of 88 to 92%. The high flow nasal oxygen is not, there's no reported benefit with that in a COPD patient. So NIV is the better choice for COPD patients because it can prevent the unnecessary mechanical ventilation. So these are the indications for NIV in COPD. The patients with respiratory acidosis with a pH of less than 7.35 and the PCO2 of more than 6.5 despite medical therapy, and severe dyspnea with a respiratory rate of more than 23 and symptom persisting after the bronchodilators and control oxygen therapy. And if the patient having the signs suggestive of respiratory muscle fatigue and increased work of breathing and persistent hypoxemia. So in these patients, we can go for an NIV, but we should exclude the contraindications before starting NIV. So the absolute contraindications are severe facial deformity, facial burn, or the fixed upper airway obstruction, and the relative contraindications are pH less than 7.15, GCS of less than 8, confusion, agitation, and cognitive impairment. So in these relative contraindications, we should actually go for mechanical ventilation, invasive mechanical ventilation. So before starting the NIV, we should do the arterial blood gas measurement, and we should repeat it while the patient is on NIV. And chest X-ray should be recommended, but we don't need to delay for that to start NIV, especially if the patient is in severe respiratory acidosis. So the reversible causes should be ruled out and treated if possible. And our choice of NIV should be BiPAP in COPD, because here we can set expiratory positive airway pressure as well as the inspiratory positive airway pressure. So the expiratory positive airway pressure is helpful to offset the intrinsic feed. And the inspiratory positive airway pressure is useful to augment the tidal volume for a given respiratory effort. So at the start of treatment, we should have a plan, individual patient plan for the escalation in case if the NIV failure occurs. And the oxygen requirement, as we already discussed, should be targeted to the saturation of 88 to 92. All gas exchange will improve with increased alveolar ventilation. So if we need to adjust the NIV setting, we should go for the pressure setting before going to the FiO2 setting. And there is a risk of mask leak and delayed triggering if we are using a high flow rate of oxygen. That can causes patient ventilator dyssynchrony. So humidification is not routinely used with the NIV, but if the patient is complaining of mucosal drying or there is a thick secretions, then we should consider heated humidifications with the NIV. And we should continue the bronchodilators with NIV, as we already discussed, when the patient is off from the NIV, or even with the NIV, we can give it through the ventilator tubing. The sedation, it's not routinely used with NIV, but with the close monitoring, we can judiciously use the sedation, especially if the patient is in anxious state and not cooperative with the ventilation. So we can have a choice of morphine 2.5 to 5 milligram with or without benzodiazepine. So monitoring, oxygen saturation should be continuously monitored, and intermittent ABGs should be done to titrate the oxygen level and the ventilate NIV setting. And if the patient's having any hemodynamic instability, especially with the high heart rate or arrhythmias, then the ECG monitoring need to be continued. So there are minor complications that can occur with NIV. The serious complications are rare, but we should monitor frequently for the possible complications. So there is the possibility of over tightening of the face mask, and that can cause us pressure injuries in the face. And there's a possibility of pneumothorax if it is occur that should be treated immediately. And if the patient have a previous history of NIV-induced pneumothorax, then we should go with the lower inspiratory pressures. But the NIV failure is another common problem. So if we are suspecting the NIV failure, then we should go for a invasive mechanical ventilation without delay. And weaning of NIV should be titrated and carried out when the pH and PCO2 become normal and the patient's clinical condition improves. So if this patient deteriorate even after the NIV, we should think about critical care referrals and mechanical ventilation. So these are the indications for mechanical ventilation. The first one is the impending respiratory arrest or peri-arrest. Other one is the severe respiratory distress and failure of the or contraindications of NIV and decreased level of consciousness, GCS less than 8, and persistent respiratory acidosis with a pH of less than 7.15. And if the experienced clinicians think that the invasive mechanical ventilation is better than the NIV in these patients, and at these situations we need to go for mechanical ventilation. So if the patient's respiratory drive is still regarding the mode of ventilation, so that's depend on the patient's respiratory drive. So if the patient's respiratory drive is still present, then we can ventilate the patient with pressure support ventilation or SIMV with the low rate and the low tidal volume preferable. But because these modes are less likely to induce the worsening of dynamic hyperinflation or auto-PEEP. But in some patients, it is not possible to go for a pressure support ventilation on or SIMV, and these patients need controlled invasive mechanical ventilation. So, for example, if the patient is having severe airflow obstruction, until the resistance falls, we need to continue the controlled mechanical ventilation. And if the patient having weak muscles and that leads to a poor triggering, then we need to continue mechanical ventilation. And to correct the chronic hypercapnia also, we need the controlled mechanical ventilation. So during controlled mechanical ventilation, the dynamic hyperinflation should be minimized by prolonging the expiry time. So the IE ratio should be set to have more time for the expiration and with a low frequency. So all these patients should be tried to be into the spontaneous breathing mode as soon as possible. And during ventilation, we should allow them to have a permissive hypercapnia with a pH of 7.2 to 7.25. Intrinsic PEEP should not be exceed 12 centimeter water in these patients. So if the patient is agitated, we should consider the ventilator's asynchrony, and sedation may be helpful at that time. And if the patients recover from acute hypercapnic respiratory failure, the ventilator requirement should be reassessed and the ventilator setting should be reviewed regularly, because if in some incidents, like without reviewing the ventilator setting, the patient may be getting more worse than the admission status because of the hyperinflation of the chest and the development of auto-PEEP. So the aim with the invasive mechanical ventilation in COPD patients, the oxygenation target is 88 to 92%, and the acid-base level should be more than pH should be more than 7.2, and permissive hypocapnia should be allowed, and the inspiratory airway pressure should be maintained more than 30. If the inspiratory airway pressure is more than 30, then we should allow permissive hypocapnia, and the low tidal volume with 6 to 8 ml per kg should be targeted, and the respiratory rate of 10 to 15 per minute should be maintained, and IE ratio should be allowed for more time for expiration. So routine performance of tracheostomy in COPD patient within 7 days or after 7 days is not recommended. So we should try to support with the NIV. That is a more preference technique for weaning rather than going straight away for tracheostomy. So there are other special therapies that can be tried in special situations. The first one is the extracorporeal carbon dioxide removal. So that can be considered in severe hypercapnic acidosis, pH of less than 7.15, despite optimizing mechanical ventilation, and when the lung protective ventilation is needed. At the same time, the patient is contraindicated for hypercapnia. For example, if the patient is having COPD and the coexistent brain injury, in that situation, the extracorporeal CO2 removal may be useful. And the mechanically ventilated patients who is awaiting for lung transplant, then the extracorporeal CO2 removal may be useful. And the Heliox, it is not routinely used for COPD exacerbations. The take-home message, so the NIV should be used only for the selected patient in acute asthma, and but the NIV can decrease the need for intubation and mechanical ventilation in COPD patients. Worsening of dynamic hyperinflation should be minimized during mechanical ventilation in patients with asthma and COPD, and permissive hypercapnia is recommended during mechanical ventilation in asthma as well as in COPD. These are my references. Thank you. Any questions? Hello.
Thank you.
Can I ask a question, Kalaimathy?
Yes, Vani. Yeah.
I was just, can you emphasize on the pathophysiology why we refuse invasive ventilation in end-stage COPD patients?
Possibly, I'm thinking like these patients may already have a high dynamic hyperinflation and auto-PEEP, and very difficult to maintain our targets in these patients with mechanical ventilation. If we try to maintain our targets, we may exacerbate the hyperinflation and the auto-PEEP in these patients, and that can compromise their hemodynamic status as well.
What about this concept that patient can't be weaned off the ventilation?
Sorry, I couldn't hear you.
Just one second. Intubated in end-stage COPDs.
Yeah.
So what's the reason for that?
I couldn't get you.
Physiology behind it.
Sorry, Vani, it's not completely coming, your sentences. Hello? Vani, can you hear me? Hello?
I think the question was why aren't end-stage COPD patients good candidates for invasive ventilation?
Why the end-stage COPD patients could not be for invasive ventilation?
Why are they not good candidates, basically? Yeah.
Yeah, that's why I was explaining earlier, like these patients are already having a hyperinflation of the chest and they have auto PEEP. So if we are putting them on mechanical ventilation and trying to achieve the targets, these hyperinflation and the auto PEEP can get worse. And on top of that, they can cause hemodynamic instability in these patients. And it's very difficult to wean them from the ventilator. Hello? Hello?
Yeah, thank you.
Thank you.